Welcome to Healthy Buzz, the podcast for women who are craving honest answers in a supported community. Hosted by Brandy Homerding, a certified nutrition therapy practitioner who believes your body isn't broken, but the narrative around women's health is. Each week, we're diving deep into holistic health topics, challenging the one-size-fits-all approach, and empowering you to trust your own informed intuition. Get ready to feel seen, supported, and seriously informed. This is Healthy Buzz, where collaboration meets unfiltered transparency in women's health. Welcome, Healthy Buzz listeners. Today, you are in for a treat. We are going to be talking about holistic treatment for menopause symptoms. I have with me today Vanessa Weiland. She is the founder of Phases Clinic, a holistic menopausal and sexual wellness clinic based in the state of Washington. As a Menopause Society Certified Practitioner, certified clinical hypnotherapist, and a board-certified Adult-Gerontology Nurse Practitioner with over a decade of experience, Vanessa is dedicated to providing compassionate care to support individuals through the menopause transition. Vanessa, welcome.
Hello, thanks for having me. It's nice to be here.
Well, I'm really excited to dive into this topic, but the first question I really have for you is how did you become interested and involved in menopause treatment for women?
Well, I had the same experience that most of my colleagues had, which is that as I was going through my nursing and nurse practitioner training in 2010 to 2012, I had almost zero education on menopause, maybe a 1-hour lecture. And for some reason, I thought that was adequate. And yet 50% of the population goes through menopause and spends a third or even more of their life in menopause. And so I was practicing mostly in the geriatric side for the 10 years after I finished school. And so I wasn't necessarily dealing a lot with the transition, but certainly was helping a lot of menopausal women. And I was doing home health, so I was listening to a lot of podcasts as I was driving around Washington, and a menopause specialist came on one of my podcasts. And I had this light bulb moment of, okay, not only was that 1-hour lecture totally inadequate, it was also really out of date, even at that time. And so our understanding around menopause and hormone therapy has really come a long way in the last 20 years. So I took it upon myself to go back, get all that training that I missed, and learn how to prescribe hormone therapy. Got trained in hypnotherapy, which I'm sure we'll get to why. And I've just decided to dedicate my career to this because it's so rewarding to really help people through this transition.
That's amazing. It is really fascinating to hear that the amount of time spent on that while you're going to school is so minimal. And so having that light bulb moment and being wow, this is something that is really going to be needed. And I could help so many people make that transition really smoothly. So can you explain to our listeners, what is menopause? What is the definition of menopause?
The medical definition is the one day in your life that you go 12 months without a period. So of course, if you aren't having periods, like you had a hysterectomy or IUD, we might go based on labs and symptoms, but normally it's just a clinical diagnosis. Menopause doesn't just stop, though. The rest of your life is considered postmenopause.
Yeah, that's a huge misconception because most people think that menopause is when you stop having a period and it's the ongoing, but that menopause is actually a 1-day event, so you can celebrate that one day and then you're postmenopausal.
There's not too much meaningful about that one day. You're not going to notice a big shift in symptoms or anything like that. But it is meaningful because we really want to know about if you have any vaginal bleeding after that 12-month mark. That's considered abnormal. So that's really the main reason to pay attention.
Right. That's a really good point. Now, sometimes also women can have this natural menopause progression when they have it naturally occurring, but sometimes women are also experiencing surgical menopause. Can you explain a little bit what that would be like?
So if you have a hysterectomy and they leave your ovaries, you're not going to go through menopause typically. But if they remove your ovaries for some reason, like maybe there was cancer or a concerning cyst or really severe endometriosis, then when you lose your ovaries, you completely lose the hormones that your ovaries make overnight. And of course, that's estrogen and progesterone, which is the standard with menopause, what you tend to lose as you lose the egg supply. But it also includes testosterone. A big portion of your testosterone is made in the ovaries. So actually, women with surgical menopause, not only is the onset so abrupt, they tend to be even worse when you factor in that loss of testosterone.
Yes, totally. That makes a lot of sense. So thinking about this transition of menopause, you kind of touched on it that like we're having that decline of estrogen, progesterone, testosterone as egg quality is diminishing, and then you're no longer ovulating, so you're never like no longer having the benefits of those hormones. So how are the symptoms that women are experiencing, what are they manifesting like? What are women experiencing when they are going through menopause and in that postmenopausal phase?
So what I was taught in that 1 hour lecture is menopause is basically hot flashes. That's it. It's a lot more than just hot flashes, although that is the most common symptom probably. But what I notice is that people will have the hot flashes and then they start digging into this a little more and thinking backwards, and they're like, you know what, actually things have been off kilter for the last 5 years. So oftentimes some of those early symptoms are a little more subtle, like maybe you're just not as resilient to stress, more anxiety, or if you had anxiety, maybe it's reaching a new level of panic. Trouble sleeping, of course, is a really common one. In perimenopause, I see a lot of difficulty with mood and sleep is two of the top things. Another common one is noticing changes, not necessarily in the number on the scale, but maybe the way your weight distributes on your body and more around the midsection.
Could you elaborate a little bit more on that as to like why that is occurring and why women experience those shifts in their weight during menopause?
There's like three main reasons for that. So estrogen has to do with the kind of stereotypical female form. So, little girls don't tend to have like the hourglass figure, and neither do a lot of postmenopausal women. So as you lose your estrogen, you tend to redistribute fat from the hips toward the belly. But also if you have a little more testosterone versus estrogen, as you start to lose your estrogen, testosterone can kind of give that like stereotypical beer belly thing that we think of with older guys. And then the third one is cortisol. There is a relationship between these ovarian hormones and your cortisol. If you have more cortisol, once again, that tends to cause weight gain in the belly. So it's coming from all sides here.
Okay, so what I'm hearing is that hormones are really important, and as we lose the power of those hormones, because they are really powerful, they have so many great benefits that as we shift, then we can start to experience a lot of these symptoms. So the perimenopausal years are going to be the years leading up to menopause, and there can be a lot of shifts happening. And I know that you mainly, like, a lot of your stuff is around postmenopausal, but I think you also work a lot with perimenopause. Can you explain a little bit about what that perimenopause phase is like, what's all involved, what the body is doing?
Yeah. I want to really briefly go back to the weight gain thing and just highlight the fact that none of those are your fault, right? You have zero control over any of that happening. So many people are like, I gained 5 pounds, but I'm still eating well and I'm exercising more. And so, yeah, it's not your fault, it's your hormones. So in perimenopause, a lot of primary care providers, if they address your symptoms, they're choosing to address it with a birth control pill, which makes sense actually, because it's replacing estrogen and progesterone, but a synthetic version of them. And basically the levels are so high that it stops your own production of hormones, and that's why you stop ovulating when you are on the birth control pill. So for some people that works great, and they basically sail all the way through until they stop using birth control because they're postmenopause. But for a lot of my patients, and maybe these are just the people that are choosing to come find me, they don't find that the birth control really covers all their symptoms, or it's creating a new host of symptoms for them. Maybe mood changes and loss of libido or vaginal dryness, all kinds of things. So they really prefer to try the menopause hormone therapy, which is most often what I'm using is exactly like what your body makes and back to the same levels that it was in your 20s and 30s. So with that said, it's not stopping you ovulating and it's not birth control. So if someone is still sexually active, they need to have that part figured out as well. Another big thing that patients come to me on is maybe an antidepressant that their primary care provider was like, oh, you're feeling more depressed and anxious. It's probably work or your kids or getting older. So here's the antidepressant, which once again actually does work because antidepressants increase serotonin. And when you lose estrogen, you lose serotonin. So it's kind of like a backdoor option to help with a lot of the symptoms, including actually hot flashes a lot of times. But once again, a lot of my patients are not wanting to go that route if they can avoid it because it's kind of like more of a Band-Aid solution than fixing the root cause.
Right, right. Another conversation I've been have recently is like, In these perimenopausal years, women are experiencing these significant changes in their menstrual cycle where suddenly they're having like very heavy and flooding periods, or the period all of a sudden like they're having these really long cycles and things are shifting. Now, oftentimes I will hear women say like, "Oh, I just want to have a hysterectomy and be done with this." Is that a viable solution? Is it really addressing the root cause? Or like, what are some things that women might have to think about? Like, okay, if you have that conversation with your medical provider and they say, yes, 100%, let's do a hysterectomy, what are the considerations they might need to have when thinking about that as a form of support for their body?
So a hysterectomy is going to solve bleeding issues, of course. It's not going to solve any of the mood changes because the wackiness that's going on with your ovarian hormones, assuming they leave the ovaries there, is still going to be going on, that disrupted signal between your ovaries and your brain. So hysterectomy is definitely a reasonable approach if your heavy bleeding is due to fibroids and you're having a lot of pain there, or endometriosis or other concerns. But if the heavy bleeding is due to this mismatch of hormone levels due to perimenopause, then I don't usually go for that first. It is a major surgery and there's big risks that can come along with that. So usually something like an IUD or a progesterone type of birth control can really limit the bleeding without having to go to the surgery option. That's like the nuclear option.
It is a major surgery.
Yes.
It is the removal of an organ, and it's the major abdominal surgery. Like, we have to think about the downtime, the recovery time, the risks involved with surgery as well. So
I've seen that too, where people are like, my PMS is so bad, just take out my uterus, but it won't fix the PMS unless they remove the ovaries, and then you're doing that surgical menopause thing that we just said is so hard. You really want to avoid it at all costs if you can. And not to mention it causes issues with bone density later on and heart health and things like that. So that's a really big thing to consider.
Hey, Healthy Buzz listeners, are you feeling like you're constantly struggling to hit your protein goals? Like, you should be getting more protein for energy, muscle support, and overall well-being, but you're not quite for sure how to make that happen without sacrificing flavor or other important nutrients. I get it. That's why I created the High Protein Power Plan, a delicious and easy to follow 7-day meal plan designed specifically for women who want to effortlessly reach 130 grams of protein or more every single day. Now, this isn't about bland chicken and broccoli. Inside, you're going to find mouth-watering recipes packed with flavor and designed to perfectly balance your macros. Think vibrant salads with protein powerhouses, satisfying bowls packed with flavor and nutrients, and easy dinner ideas that make hitting your goals a breeze without feeling deprived. This plan takes the stress out of high-protein eating and helps you feel your absolute best. Ready to finally unlock the power of high protein without the guesswork? Head on over to bcw.becollectivewellness.com/high protein recipes to download your high protein power plan today. That's bcw.becollectivewellness.com/high protein recipes. It's time to nourish your body, feel amazing, and discover how delicious hitting your protein goals truly can be. So when we're thinking about hormones, can you tell me a little bit about like the hormone therapy myths that are out there?
So 2002, I believe, a study came out called the Women's Health Initiative. And still to this day, it's the largest ever study looking at hormone therapy versus placebo. And they had 4 groups in that study. If the women had a hysterectomy, they either did a placebo or estrogen all by itself, because you don't necessarily need progesterone if you've had a hysterectomy. And then for the women that had their uterus still, they did either placebo again or an estrogen plus a progesterone. But in both cases, it was the type of estrogen that comes from horse urine. It's mostly fallen out of favor, but that was like the original hormone therapy for dozens of years in the 1900s. So they were using that. And then they were using a synthetic form of progesterone called medroxyprogesterone acetate. And they actually stopped the study early because they found a higher risk of heart disease, which went against all the other studies up to that date. So that's always a big deal when they stop a study early for safety concerns. But in this case, they had a press conference, which is out of the ordinary because they hadn't actually analyzed all the data yet. And they said, hormone therapy increases your risk of heart disease, and we found a higher risk of breast cancer. That part was really weird. And if you have any background in research, You'll know why this is weird, because it was not statistically significant. And we don't report findings that aren't statistically significant as a real finding. It could have happened by chance. That's the whole point of statistical significance. So it's really weird that they announced this, but basically there was pandemonium. People were flushing their hormone therapy down the toilet. Doctors were getting sued, the whole thing. And it really just shut down hormone therapy for now we're like 25 years past and still not to the same degree it was at. So luckily somebody came along and said, let's look at this data a little bit more closely. And they split the group into 3 parts. Women that were 50 to 59, 60 to 69, and 70 to 79. And it turned out that increased risk of heart disease was only driven by the women 70 to 79. The women 50 to 59, it was lower risk of heart disease. It is actually matched up with what they had been finding in the 1980s and 90s. So now we think there's basically a window of opportunity. If you're wanting to get heart benefits from hormone therapy, it's best to start it in the first 10 years after menopause. That doesn't mean you have to stop it after 10 years. It's just, it matters when you start it. And that's really how we tend to use it anyways, right? We tend to start it when symptoms are the worst, right around the age of menopause, and then continue if their benefits outweigh the risks. So I'm really glad they did that reevaluation. And then the breast cancer thing was also very funky because the estrogen only group, the ones that had their uterus removed, actually had a lower risk of breast cancer. So we know that the estrogen piece, or at least the horse urine estrogen piece, is not a concern with breast cancer. And there's been a lot of studies now that have replicated that. So we really think the bad actor in that was that synthetic progesterone, hydroxyprogesterone acetate, and that has really almost no one uses it anymore. I've only had like 1 patient come to me on that. So nowadays we tend to use what's called bioidentical micronized progesterone, which looks exactly like what your body makes. I mean, they're still making it in a lab. It's not coming off of a tree or anything like that, but it's considered the more natural hormone. With that, we don't have this giant study that spanned many years with so many tens of thousands of women, but we do have other, smaller studies showing no increased risk of breast cancer, at least for 5 years. So basically, the breast cancer concern, it's there. I still counsel all my patients on that. But even in that study, the increased risk was less than 1 extra case per 1,000 women. For some people, that's a deal breaker. And for others, they're willing to take that risk to get some of the other benefits.
Question I have about HRT. We hear about bioidentical HRT and HRT. Like HRT stands for hormone replacement therapy for people who don't know. And I one time heard a doctor say on Instagram that all hormone replacement therapy is bioidentical hormone replacement therapy. And I was like, I feel like that's a false statement, but I didn't feel confident enough to call that person out. But can you explain that a little bit more about the HRT, bioidentical? What does that actually mean so people can have the better conversations with their providers?
Yeah, that's funny. I think I might have seen that post too. And I'm like, who is this person? Well, first of all, bioidentical hormone, HRT, is kind of a made up term. It's not a medical term. But it's the same idea I've been talking about, where the chemical structure looks precisely like what you would make if someone drew your blood. It's still synthetic in the sense it was made in a lab somewhere and purified and all that stuff. Versus synthetic hormone therapy is something that's very similar, but they changed it a little bit because it was easier to put it in a pill or in a patch or, whatever the reason. It was cheaper, so those look very similar, but just not exactly the same. So that's kind of the difference between bioidentical and, standard HRT. Bioidentical is underneath HRT, if that makes sense. It's still considered HRT. Some people have kind of run with that term and said, well, bioidentical is safest, which actually I agree. I think the data definitely points in that direction. And you can only get it if it's compounded, or you can only get it in a pellet. That part's not true. That's where they're getting a little bit skeezy, is if they say you can only get bioidentical hormones if it's compounded, because you can go to your local Rite Aid and your provider can order bioidentical estradiol patches and your insurance will cover it. So I use compounding sometimes. Sometimes it makes sense because of an allergy or something like that, but it's never my go-to because insurance coverage is actually pretty good and these can be really affordable.
Can you tell us what forms? So you kind of mentioned a couple, there's the compounding. And when you're telling us about compounding, is that topical? Is that something taken orally? What forms do hormones come in? And is there something that works, quote unquote, better or that it's safer than maybe other routes?
Yeah, this is a super nuanced discussion, but it's what I have every day in my clinic. So the typical dose form that I start with is micronized progesterone, which is an oral capsule. It doesn't seem to absorb quite as consistently through the skin, and it can be given vaginally, and we have safety data there, but we don't have a cheap, easy option to do that. So some people get kind of crafty and put the oral pill in their vagina, or we might compound a vaginal suppository. So that's where I start with progesterone. And then with estrogen, I usually start with a patch because we do have some data showing that it's safer to put it when it goes through your skin rather than taking it orally. When you take it orally, it gets digested through your liver, and that messes with your clotting factors. It messes with your thyroid hormone, your testosterone hormone. So if we can go directly from the skin into the bloodstream, we bypass all that. So I like that, but it's not a total deal breaker if someone's like, it's just easier for me to take a pill, I want to do it that way. It's fine. It's still very safe. It's just if I can be as safe as possible, I will be. And then I tend to start with the patch simply because it's the cheapest, but there are some other really nice forms like gels and sprays and even a vaginal ring that you just set it and forget it for 3 months.
Something that you also mentioned is that if you've had a hysterectomy, you don't need progesterone necessarily. You can do just estrogen. Now, why, if you haven't had a hysterectomy, you still have your uterus, why do we need to have that progesterone in addition to the estrogen?
That's a really good question. So when you're still menstruating and ovulating, estrogen's role in your body is to basically build up the lining of the uterus and kind of prepare for maybe you having a fertilized egg. And then assuming that doesn't happen, no fertilization happens, progesterone, at first it kind of stabilizes the lining, but then it just says, we don't need this, and thins it out, and that's what starts your period. So they kind of have this yin and yang relationship in your uterus. So if you only use estrogen, it's going to build up that lining and just keep building and building and building without the thinning out process happening. And that could actually lead to cancer. So we really don't want to do that. On the flip side, if you don't have a uterus, you can use estrogen only because there's no danger of that. I have patients that actually like the progesterone for other reasons, and they use it even though they have had a hysterectomy. It's just not medically necessary, if that makes sense. And it's safe to do a progesterone by itself. I have some patients that don't need estrogen yet, but they're using a little bit of progesterone to help with sleep. And in that case, you don't need the estrogen. It's just the estrogen that needs the progesterone, if that makes sense.
Okay. Yep, that makes sense. You also mentioned that it's best to start hormone replacement therapy within 10 years of menopause. If somebody was like 12 years post or 15 years post, does that mean that they're automatically not a candidate, or can you elaborate a little bit more about that?
I definitely consider those folks on a case-by-case basis. Like I kind of alluded to earlier, the big concern is around heart disease risk. At that point, we're probably not getting a big benefit, but we also want to make sure we're not causing a risk of harm. So usually what I do at that point is kind of look into the risk factors for heart disease, and if they're quite high or we already know this person has heart disease, I think probably I'd be more likely harming them. But if they don't have big risk factors for heart disease, no high cholesterol, no high blood pressure, no heart disease in the family, they're very active, let's say they have osteoporosis in the family, well, in that case, the benefits actually really probably outweigh the risks. So it's a super case-by-case situation. But I wouldn't say just rule someone out based on their age.
When somebody starts then, is it something that they can be on for the rest of their life?
So this is a big debate these days, but none of the guidelines, medical guidelines, say you have to stop hormone therapy at any particular age, after any number of years. They all just say continue reevaluating that the benefits outweigh the costs. I don't stop hormone therapy at any particular point in time. It's just looking at those benefits. You know, a lot of people's symptoms do go away. So you're losing that big benefit of helping through the menopause transition. But there are other potential benefits around your bone health, perhaps your heart health. The data is still out here, but maybe even brain health, and prevention from dementia. You can make a pretty strong argument to stay on it for a lot of people. There was actually a really interesting study that came out last year, 2024, on Medicare recipients. So of course, most of them are over 65. And it was, I think, like 10 million Medicare recipients. So it wasn't a randomized trial that we really prefer, but it was a huge trial as far as numbers. And the women on hormone therapy had less heart disease. The women only taking estrogen actually were dying later in life, had better heart health, less breast cancer risk, all kinds of benefits. And the women that were on the combined therapy we've been talking about, where it's like an estrogen plus a progesterone or a synthetic progesterone, they didn't have a lot of the risks that you think of. They didn't have more risk of dementia or stroke or blood clot, but they didn't have quite so many benefits as the estrogen only group. So that really reassured me to continue hormone therapy long term for the people that want to.
When you're mentioning like evaluating, what does evaluating look like? Are you evaluating just symptoms? Is there like a blood draw? What does that mean?
Sometimes I'll check the blood levels, especially for testosterone. I always check the blood levels because not everyone gets low in testosterone after menopause, or even during perimenopause, I should say. With estrogen and progesterone, there's reasons to check it, but often the labs can be deceiving. So I have quite a few perimenopause patients that come to me and they're like, I had these symptoms, I talked to my primary, they finally agreed to do the labs, and then they were normal, and like conversation just stopped there. So I think a lot of people are almost using the labs as a weapon. So I'll check them, but like with all those caveats, like it's probably going to come back normal. But sometimes it can kind of help guide treatment, like especially let's say someone did have a hysterectomy and they're like, I'm just curious if I'm like through this already or if I'm still in the middle of it. And we can check labs and get a better sense of that. But they just go up and down so much during this period that it's really hard to make heads and tails with it. So I usually mostly go based on symptoms.
Great. And circling back, I forgot to ask and follow up to the different types of hormone therapy. You mentioned pellets briefly, but we didn't go into like what pellets are and how they work.
Pellets are a systemic form of hormone therapy where this tiny little pellet is put under your skin, usually like your butt, hip area, and it's going to slowly dissolve and let the hormone come out. A lot of times it's estrogen or maybe estrogen and testosterone. And it lasts for about 3 months, and then they put a new one in and so on and so forth. I'm very wary of them because once it goes in your skin, you can't like actually dig back in there and find it and pull it back out again. So if we go too high on the doses, you're just stuck. If it's too low, it's like, okay, it's not the end of the world. Maybe we'll do a little bit more on top of it. But too high, which happens a lot, people are really just stuck with those symptoms for 3 months. I mean, that's a lot. And I think like some of the pellet manufacturers have more dosing options than others, and certainly some providers are more knowledgeable than others. So I think there's a way it can be done safely, but that's why I'm really wary of it, particularly with testosterone, because if we go too high on that level, then you can actually cause permanent changes like a deeper voice, a larger clitoris, things like that, where, that's a big deal. Not to be taken lightly unless that's what someone's goal is.
So we've talked a lot about estrogen and progesterone, and we will come back to vaginal estrogen, but let's talk a little bit about testosterone. We haven't given them really the limelight. You brought it up about like in pellets, but like why do women need testosterone? What's the role of testosterone in women's health?
Well, the main role is that it is a part of your ovulation. So your testosterone peaks the same time when you're ovulating as your estrogen. It's funny, if you look at the lab levels, they'll basically count 0 as normal for women. So we haven't like totally elucidated all of the roles of testosterone in women's health, but it is normal for you to have testosterone in your body. And in fact, most of the time, if you compare testosterone versus estrogen levels, there's more testosterone than estrogen. But testosterone is part of the cascade. It actually converts into estrogen, but it sticks around on its own too. The area where we really have the most research and the most clarity is around testosterone and your sexual health. That includes things like libido and arousal, ability to climax. All those things are dependent on not just testosterone, but other androgens. They're called androgens because we think of them as like male hormones, but they're not. We just cover that. They're in everybody. And so that's where we have the most data. We have guidelines around using testosterone for helping with libido in women that are postmenopause. We're gathering more and more kind of what we say anecdotal data or anecdata, where women are using testosterone. Maybe they started it for their libido and then they're saying to themselves, but I'm also feeling so much more mentally clear, or I have better energy, or I'm finally getting the gains when I go in the gym and like building that muscle mass. So we have that data, but it's pretty much just in men that are using testosterone replacement for low testosterone. We just don't have a ton of the data in cisgender women. I think we have a fair amount of safety data, so I don't think that there's an overwhelming risk of harm, assuming we're staying in like a normal level for cisgender women. If we're going super high, then yeah, we can cause those side effects like the facial hair or head hair loss or deeper voice. But as far as my patients go, it seems to be worst case scenario is like a little bit more acne, maybe your chin hairs get some friends, but otherwise mood wise it seems fine. And then some people just get huge benefits as far as their energy, their mood. And then of course desire is a common place where we see improvement. But I have to say I have a subset of people that we get their testosterone level where you would typically see a response and they still don't really notice more desire. So it's, sexual desire is such a complicated thing that you can't necessarily just like press this on switch and it's going to work for you.
Right. It can be a lot more involved than just your hormones. Estrogen also plays a role in libido too. It's not,
Yes.
Testosterone, yes, 100%, but so does other hormones as well.
That's right. Yeah, I have a lot of patients that never touch testosterone, but just the other hormone therapy and helping with vaginal dryness, their libido gets a lot better.
Yeah, amazing. So let's go back to vaginal estrogen. Tell me more about that. Who is a candidate? Who's not a candidate? Why is it beneficial?
Everybody's a candidate. There's been so much debate around vaginal estrogen, specifically in breast cancer survivors. That's really the last holdouts on it. We've had more and more studies and meta-analyses looking at that particular population showing safety, meaning not only do they have no increased risk of breast cancer recurrence, but they actually have better survival, probably because there's less UTIs and things like that. And then finally, we just had a new guideline from, I might be saying it wrong, but I think the American Urological Association saying, yes, we can use it in breast cancer survivors. Another cancer advocacy group said, yes, we can use it for breast cancer survivors. American College of Obstetricians and Gynecologists says it too. So finally, we're getting there, like literally as of 2025. So I use that without concern in breast cancer survivors and, those currently undergoing treatment because the data is so consistent that it's not harmful. Who else is a candidate? Someone that has had blood clots in the past. There's no increased risk of blood clot with vaginal estrogen. Your 92-year-old grandma that's getting UTI after UTI and landing in the hospital over it, she's a candidate for vaginal estrogen. Maybe you need to be thoughtful about the way you're giving it because they might not have the dexterity. But honestly, it's my biggest regret having worked in geriatrics is not handing it out left and right because it's basically just skincare. It's not being absorbed into your bloodstream and those tissues just soak it up. They love it and it makes them much healthier. It fixes the microbiome in your vagina and there's no downsides except cost, or some of my patients don't like the texture of it or something, but it's not being absorbed systemically to cause systemic side effects.
That's amazing. So biggest takeaway is everybody should be advocating for this as they go become postmenopausal for their moms, their grandmas. These are conversations that you can be having with them and helping them advocate for themselves. Okay, so question that just to throw out there, a lot of times people maybe feel a little resistant to starting any type of HRT. And so they are wondering, are there any supplements that I can take instead of HRT?
We received medical guidelines from the Menopause Society around how to treat menopause symptoms. And they did address this question in 2023. They had a guideline about non-hormonal treatments for hot flashes. And they specifically did address all the different supplements out there and basically said we don't have strong enough evidence in pro of any of them. I think there were a couple that they kind of specifically called out and discouraged. But as you said, a lot of people want to address their health that way, maybe just because that way they can access it whenever they want to, or maybe cost is a barrier. Access we've already talked about. A lot of healthcare providers aren't so knowledgeable here. So I have really dug into the data on supplements, what seems to be more effective, or at least what's the minimal risk of harm, because I don't want someone to take something that's going to hurt them. And it seems like there's quite a few options out there that you can safely give it a try and see if it's going to be helpful for you. I think probably the best evidence is for soy isoflavones, so you can increase soy in your diet or take the supplement. There's even a little bit of safety there around breast safety. Basically, these are like plant compounds that kind of look like estrogen. Kind of like how we were talking about earlier, synthetic estrogens look similar but not exactly the same. These are plant compounds that are like that, and so they are stimulating those receptors and helping with things like hot flashes or other symptoms. But you do need to think a little bit about safety because maybe it's also activating those receptors in your uterus and growing that lining in the dangerous way that estrogen can. So we tend not to have a ton of safety data with that sort of thing. But there is some around soy isoflavones that at least for several years they're not showing that the lining is growing too much. So that's a common one that I'll recommend. Black cohosh, there's been a lot of interest in that one. It's kind of a nice choice for if someone's worried about hormones because it doesn't seem to work on the estrogen system at all. But there's some potential risk of harm there where maybe it will mess with your liver. People think about supplements and they're like, oh, it's natural, so it probably can't hurt. But there actually is always a risk of harm. You never know how it's going to interact with your other supplements or your medications or your medical concerns. So there are some people out there that kind of specialize in that. And sometimes the pharmacist can be a good resource, or like a local herbalist, naturopath, things like that. People who have a little bit more knowledge of the potential interactions and downsides. But I don't want people to be too loosey-goosey about it because there are potential risks there.
Yeah. And something that I heard too is like, those are great, but depends on your need too. Like, they might not pack as powerful of a punch as like HRT will, where you can really fine tune your dosage a little bit more and give yourself a little bit more. I mean, like, how much soy can you eat in one day, right?
It won't ever be as potent. That's definitely true.
Here's a really big question. What do you say to the people who are having the major pushback from their providers when they're like, hey, I'd love to explore HRT, and they're like, nope, and they kind of shut it down?
Yeah, it depends a little bit on your relationship with the provider, because everything that I've been talking about today, there's a guideline you can go print out. Public use, the Menopause Society guideline on hormone therapy is the one that says, yeah, if you're within 10 years of menopause, none of these major risk factors, the medical benefits outweigh the medical risks. Like, it's in black and white for you. So sometimes you can just like print it, highlight it, show it to your provider. And depending on the provider, if they're more open, they might be like, oh, yeah, I see what you mean here. But they might not know how to prescribe it. If they were never taught how to prescribe it, they're just kind of, it's the blind leading the blind. So oftentimes if you hit resistance, I do recommend trying to find a menopause specialist. There's a few different lists to try to find somebody. Menopause.org is a big one people point toward, but there's others. What I often recommend with my patients is let's work together for a few months, get you on the right regimen, and then check in again with your PCP if they're willing to take over prescribing, and the vast majority actually are. So I think that's kind of a nice way to get through that hurdle.
I love that. So this is such a wonderful conversation. I think people are really going to find a ton of value in everything that you talked about. Where can people find you? How can they connect with you?
Well, if you live in Washington State and you're inspired to see me as a patient, phasesclinic.com, you can request an appointment or, a meeting with me. And then if you don't live in Washington, but you want to learn more about like this holistic care of menopause, really evidence-based around what supplements do we have research for, what lifestyle changes do we have research for, what medication management options can I maybe bring to my own provider, phasesacademy.com is where I put a lot of content. And then also Instagram, I have tons of free content there. So you can find me at phases.clinic.
All right. Is there anything else you want our listeners to know before we part ways today?
Yeah, just be that squeaky wheel, advocate for yourself. Don't listen to anybody that tells you just suck it up. All women go through this. It was worse for me. Like, just block all that out. You don't need to suffer. You deserve to feel your best. And most likely hormone therapy's benefits would outweigh the risks for you.
Amazing. Well, Vanessa has put together a freebie for us so you can check out in the show notes. I have for you a guide of evidence-based supplements for common menopause symptoms. So make sure you go there, check it out. Follow Vanessa on Instagram. Reach out to her if you have questions, want to schedule an appointment. But this was such a wonderful conversation. Thank you so much, Vanessa.
Thank you so much for having me, Brandy.
Thanks for tuning in to another episode of Healthy Buzz. I hope this conversation has left you feeling seen, supported, and ready to take the next step in your health journey. Love what you heard? Make sure you subscribe to Healthy Buzz so you never miss an honest conversation. And if you found this valuable, please take a moment to leave a review. I truly appreciate it. For exclusive weekly tips and holistic strategies, be sure to subscribe to my weekly newsletter. The link is in the show notes. Remember, this isn't just nutrition, it's permission to trust your body. I'll catch you on the next episode of Healthy Buzz.